What's up?
First of all, to understand how Budd-Chiari Syndrome develops, we have to recall Splanchnic circulation.
We got to take care of our immortal souls. You know you can't read. It's the Bible, you get credit for trying.
Initially, left ventricle pushes blood into the aorta, and from aorta blood is going into the splenic artery that supplies blood to the spleen, and mesenteric arteries that supply blood to the intestine, where in mesenteric capillaries fluid exchange occurs. To explain this, recall that cardiovascular system is a closed system, where fluid exchange occurs in capillaries because capillaries have pores. So we have afferent vessel that delivers blood to capillaries, we have afferent vessel that provides outflow of blood from capillaries, and we have capillaries that have pores. Through these pores in capillaries, fluid with nutrients can enter to the interstitial space. From the interstitium, cells that compose a particular tissue receive vital substances. But some portion of fluid after this usually remains in the interstitium. And then the lymphatic system drains the excess fluid from the interstitial space into the venous system. The amount of fluid that crosses capillaries and enters to the interstitium depends on filtration rate. And filtration rate is described by Starling equation. Filtration rate is equal to hydrostatic pressure difference between capillaries and interstitium minus oncotic pressure difference between capillary and interstitium, and directly proportional to hydraulic conductivity. It's a simplified version of equation because in this case, to simplify, we suppose that values as oncotic reflection coefficient and surface area are constant. First of all, we see that hydrostatic pressure difference is the main driving force that pushes fluid out of the capillary. Oncotic pressure difference is the force that keeps fluid inside the capillary, and hydraulic conductivity, in fact, just describes how permeable is the membrane. And it's a general concept of fluid exchange that can be applied to every tissue. In case of intestine, mesenteric arteries delivers blood to mesenteric capillaries, mesenteric veins provide outflow of blood from capillaries, and cells that compose intestinal tissue called enterocytes. Then blood from the spleen by splenic vein and from the intestine by mesenteric veins is delivered to portal vein. Portal vein drains blood into the liver, where in liver capillaries that we call sinusoids, fluid exchange occurs. The principle is the same. The difference is that in case of liver tissue, the vessel that delivers blood to liver capillaries is portal vein, liver capillaries called sinusoids, the vessel that provides outflow of blood from capillaries is hepatic vein, and cells that compose liver tissue called hepatocytes. After fluid exchange in liver capillaries, blood is going to hepatic vein, and from hepatic vein, blood is drained to inferior vena cava. But also we have to know that in this system we have additional vessels that remain from embryogenesis. Such vessels we called portosystemic collateral blood vessels. Back in times of embryogenesis, these vessels were crucial. They provided flow to esophageal and gastric veins. Also they provided flow to paraumbilical and superficial epigastric veins that are located on anterior abdominal wall, and also they provided flow to upper anal canal veins. And from all these veins, blood is drained into the inferior vena cava. Adult person in normal condition practically do not use portosystemic collateral vessels, because adult person has portal vein pump line that provides flow of huge amount of blood. From inferior vena cava, blood goes into the right atrium and right ventricle of the heart. Then blood crosses pulmonary circulation and goes into the left atrium, left ventricle, and from left ventricle again heart pushes blood into the aorta. So this cycle can be repeated over and over again.
What are you looking at? Back to work!
So let's suppose that thrombosis of hepatic vein occurs. The flow from liver sinusoids to inferior vena cava is equal to pressure inside the liver sinusoids minus pressure inside the inferior vena cava divided on resistance between them. And resistance is inversely proportional to the force power of radius. So if thrombosis occurs, then radius inside the hepatic vein decreases, With decrease in radius, resistance increase and flow through this area decrease. So the inflow of blood to liver sinusoids remains the same. The outflow of blood decreases due to a thrombosis. This results in accumulation of fluid proximal to the thrombosis. Initially, blood begins to accumulate in liver sinusoids. First of all, it will affect liver tissue and cause so-called nutmeg liver and hepatomegaly. In addition to this, increase in volume of fluid inside the liver sinusoids cause increase in hydrostatic pressure, and the increase in hydrostatic pressure cause edema of the liver tissue that manifests with ascites and abdominal pain. To explain how all these symptoms develop, let's take a closer look at fluid exchange inside the liver tissue.
Gentlemen.
So we have fluid inflow to liver sinusoids that is provided by portal vein, and fluid outflow from the liver tissue that is provided by hepatic vein. In normal condition, they are in balance, but if thrombus in hepatic vein is formed, it will cause obstruction of the vein, and with obstruction, flow through the venous circulation decrease, because recall that flow equals to pressure difference divided on resistance, and resistance is inversely proportional to the radius. So if thrombus is formed, it will cause obstruction of the vein. Thereby, radius of the vessel will decrease. With decrease in radius, resistance increase, and with increase in resistance, flow through this region will decrease. So with formation of a thrombus, the outflow of blood decrease, but the amount of blood that is delivered to liver tissue by the portal vein remains the same, because nothing is wrong with cardiac output. So blood inflow to capillaries becomes higher than blood outflow. As a result, blood begins to accumulate inside the liver sinusoids. The volume of blood in liver capillaries will increase, and with increase in volume, hydrostatic pressure increase, and increase in hydrostatic pressure cause increase in filtration rate. Because recall that hydrostatic pressure is basically a weight of fluid that acts on a particular area, and weight of fluid equals to mass of fluid times gravity constant. In turn, mass of fluid equals to fluid density times fluid volume. As we see, volume and hydrostatic pressure are directly related. So in Budd-Chiari syndrome, thrombosis or compression in venous circulation cause obstruction to flow. This results in increase in volume of fluid inside the liver sinusoids, and the increase in volume of fluid cause increase in hydrostatic pressure that results in increase in filtration rate. So the higher the capillary hydrostatic pressure, the higher becomes filtration rate. So the more fluid will cross from sinusoids to the interstitial space, and at some point fluid income to the interstitial space will be higher than lymphatic drainage, so fluid will progressively accumulate in the interstitium, and the accumulation of fluid in the interstitial space will cause edema. From the interstitium, fluid leaves liver tissue and is going into the space between liver tissue and liver capsule. And accumulation of fluid in subcapsular space causes distension of the liver capsule. And because liver capsule has a lot of nerve endings, distension of the liver capsule causes abdominal pain in the right upper quadrant. Also, some portion of fluid leaks through a capsule into the abdominal cavity, and accumulation of fluid in the abdominal cavity called ascites. Another problem is that, as we see, a lot of blood gets stuck and accumulates in the liver tissue. But it's venous blood, and thereby it's blood with low amount of oxygen. So to explain this, in normal condition in liver sinusoids, oxygenated blood prevails over deoxygenated blood, because any tissue requires oxygen for aerobic metabolism, like electron transport chain for example. With thrombosis or compression that cause backup of venous blood, the amount of deoxygenated blood increase, and the amount of blood with oxygen decrease. So at some point, accumulation of blood without oxygen will provoke ischemia of hepatocytes, and with ischemia, aerobic metabolism decrease, and as a result, hepatocytes undergo fat dystrophy that results in formation of lipid droplets inside them. Congested and dilated hepatic veins give this red-brown color to liver tissue. Lipid droplets give this a little bit of pale yellow color, and together this combination of red-brown and yellow color resembles a nutmeg. So because of this, we call such liver tissue a nutmeg liver.
I like it. Simple, easy to remember.
With time, the backup of blood due to a thrombosis causes accumulation of blood inside the portal vein. With accumulation of fluid, hydrostatic pressure inside the portal vein increases. And increase in portal venous pressure we call portal hypertension. So portal hypertension develops. And the combination of portal hypertension and the obstruction in hepatic vein force a larger volume of blood to go into the portosystemic collateral vessels. These vessels also called portosystemic shunts. The problem with it is that the more severe becomes portal hypertension, the higher volume of blood is going into the portosystemic collateral vessels. And the higher the volume of fluid inside these vessels, the more distended they become.
Are you telling the truth?
Every word, love.
So to explain this, there is a vessel with fluid inside it. Fluid flow occurs from left to right, and fluid has some hydrostatic pressure. And as we know, hydrostatic pressure acts in all directions. Recall that hydrostatic pressure is basically a weight of fluid that acts on a particular area. And weight of fluid equals to mass of fluid times gravity constant. In turn, mass of fluid equals to fluid density times fluid volume. So basically, volume and hydrostatic pressure are directly related. Also, we have to know that because hydrostatic pressure acts in all directions, it determines the wall tension. Recall that wall tension is determined by the Laplace law. Laplace law states that the wall tension is equal to pressure difference between the pressure that acts from the inside of the vessel minus pressure that acts from the outside of the blood vessel. Also, wall tension is directly proportional to the radius of the vessel and inversely proportional to the thickness of the vessel. So the higher the volume of fluid inside the vessel, the higher becomes hydrostatic pressure, and with increasing hydrostatic pressure, wall tension increases.
You see, there is only one constant, one universal. It is the only real truth. Causality. Action, reaction, cause and effect.
So in this case, the inflow of blood to portosystemic collateral vessels increase. With increase in fluid inflow, more volume of fluid will be located inside the vessel. With increase in volume, hydrostatic pressure increase. With increase in hydrostatic pressure, wall tension increase. Increase in wall tension causes vessel wall distension. Because collateral vessels are veins and veins have very high compliance, they can be very easily distended. Basically, they are like balloons. And such over-distended veins we call varices.
You actually were telling the truth. I do that quite a lot, yet people are always surprised.
Distension of esophageal veins and gastric veins cause formation of esophageal varices and gastric varices. Distension of paraumbilical and superficial epigastric veins cause formation of Caput medusa on anterior abdominal wall, and distension of upper anal canal veins cause formation of hemorrhoids. The problem with varices is that the more distended they become, the higher is the chance of their rupture.
A truly discomforting notion, love.
So with time, due to a thrombosis, the higher volume of blood becomes stuck, initially in liver sinusoids, and then blood begins to accumulate inside the portal vein. The more blood accumulates, the more severe becomes portal hypertension. The more severe becomes portal hypertension, the more volume of fluid goes into the portosystemic collateral vessels. So with time, the inflow of blood to portosystemic shunts increase, so the volume of fluid inside the shunts increase. With increase in volume of fluid, hydrostatic pressure inside the shunts increase. With increase of hydrostatic pressure, wall tension increase. Increase in wall tension causes more severe vessel wall distension. And with time, if portal hypertension becomes even more severe, even more fluid will pass through the collateral vessels. Increase in fluid inflow causes increase in fluid volume inside them. Increase in volume of fluid causes increase in hydrostatic pressure. Increase in hydrostatic pressure causes increase in vessel wall tension. And when wall tension reaches a critical level, the force that is applied by hydrostatic pressure to blood vessel wall will prevail over the ability of the vessel wall to distend. and when this happens, critical wall tension causes rupture of the blood vessel. So the more severe becomes portal hypertension, the higher the chance that rupture of esophageal varices will happen, and this will cause upper GI bleeding. Also, the Caput medusa on anterior abdominal wall will become more prominent, and also the higher the chance that rupture of hemorrhoids will occur, and this can cause lower GI bleeding. Also, flow that bypass liver is non-physiologic. Recall that in our blood we have some dangerous substances as free ammonia and unconjugated bilirubin, and the organ that provides their detoxification is liver. In normal condition, portal vein pump line delivers blood to the liver, where liver makes from dangerous ammonia molecules a urea molecule, which is less harmful substance. And also liver provides conjugation of bilirubin, and only after blood is going to inferior vena cava. But blood that inflow to shunts bypass liver, thereby blood do not undergo any detoxification. As a result, first of all, it can cause increase in blood ammonia level, that can cause hepatic encephalopathy, and also it can cause increase in free bilirubin level that manifests as jaundice. So increase in blood flow through the portosystemic shunts cause increase in blood ammonia level that can cause hepatic encephalopathy, and also it can cause increase in free bilirubin level that can cause jaundice. After portal vein, blood begins to accumulate in the splenic vein and after in the spleen. Increase in blood volume inside the spleen causes spleen distension, and enlargement of the spleen we call splenomegaly. Also, blood begins to accumulate in mesenteric veins and after in mesenteric capillaries. With increase in volume of blood, hydrostatic pressure inside the mesenteric capillaries increase. Increase in hydrostatic pressure inside the mesenteric capillaries causes edema of the mesenteric tissue that results in ascites. So let's explain why ascites develops.
Right, you like this?
We have blood inflow to mesenteric capillaries and blood outflow from mesenteric capillaries initially into the portal vein, then into the liver sinusoids, and after into the hepatic vein and inferior vena cava. So if thrombus in hepatic vein is formed, this causes a backup of blood, because recall that flow equals to pressure difference divided on resistance, and resistance is inversely proportional to the force power of radius. So if thrombus is formed, it will cause obstruction of the blood vessel. Thereby, radius of the vessel will decrease. With decrease in radius, resistance increase, and with increase in resistance, flow through this region will decrease. So thrombus causes backup of blood because our cardiovascular system is a closed system. So in the veins, fluid just cannot disappear. So fluid begins to accumulate initially at the proximal regions of hepatic vein, then at liver sinusoids, then in portal vein, and finally in mesenteric capillaries. So we can say that fluid outflow decreases, but fluid inflow to mesenteric capillaries remains the same. As a result, fluid begins to accumulate inside the mesenteric capillaries. With increase in fluid volume, hydrostatic pressure increase. Increase in hydrostatic pressure causes increase in filtration rate. Because recall that volume and hydrostatic pressure are directly related. So in Budd-Chiari syndrome, thrombosis or compression in venous circulation cause backup of blood that results in increase in volume of fluid inside the mesenteric capillaries. Increase in volume of fluid causes increase in hydrostatic pressure inside the mesenteric capillaries that results in increase in filtration rate. So the higher the capillary hydrostatic pressure, the higher becomes filtration rate, so the more fluid will income to the interstitial space. And at some point, fluid income to the interstitial space will be higher than lymphatic drainage, so fluid will progressively accumulate in the interstitium, and accumulation of fluid in the interstitial space will cause edema. From the interstitium, fluid leaves intestinal tissue and is going into the abdominal cavity, and accumulation of fluid in the abdominal cavity called ascites.
Nice one.
So, as we see, Budd-Chiari syndrome has numerous symptoms. It's liver pathology that is characterized by ascites of hepatic origin, abdominal pain, nutmeg liver, and hepatomegaly. Also, portal hypertension develops that cause formation of varices. It's esophageal and gastric varices, Caput medusa, and hemorrhoids. Also, shunts cause increase in blood ammonia level that can cause hepatic encephalopathy, and increase in free bilirubin level that can cause jaundice. And finally, it can be complicated by rupture of the varices that can cause upper and lower GI bleeding. Also, the size of the spleen increase, and in addition to this, ascites of mesenteric origin develops.
Great. Fine. Yep. Ciao. What's that mean? Ciao. It's Italian. Means food.